My name is Carolina Avendaño, and I am the Director of Research Operations for the Children Environmental Health Initiative, and that's the CHI, as we refer to it. And we are, CHI basically is a research and education and outreach program committed to fostering environments where all people can foster. And we have a really deep commitment to issues of social justice. And so we focus a lot of our work in low income and minority communities. And part of our efforts and our projects are usually having to do with how we mix both the social factors and how environmental factors influence the health outcomes of children, but also other vulnerable populations like older populations. And so we, if you heard in the previous panels, we have one of our, since we're newcomers to the Indiana community, we have tried to start one of our efforts here, which is our Indiana COVID-19 registry. So I'll take one little moment here to take another pitch at it. And so if you can help us outreach the community, because the more data we get, the better we can then have actionable data that can impact our local communities, and beyond that we can then inform. So just I'll leave it there, and then I'll have the pleasure to introduce our panelists for this forum. And our topic today will be social underpinnings of understanding the impact COVID-19 has on individual and societal behavior and outcomes. And we have three wonderful speakers, and we have Kate Bolten, who's our Associate Professor of Anthropology. And then we will have Jerry Haeffel, I'm so sorry if I mispronounced that last name, which is our Associate Professor of Psychology, which he also has some of his students. And then Terry, who's McDonald, who is our Associate Professor of Sociology, and as well as the Director of Graduate Studies, and also concurrent faculty in the Kilk School of Global Affairs. We will start with Kate, who will talk about, because of COVID, making sense of excess deaths during a pandemic.
Thank you so much, Carolina, and thank you everybody for joining us for this forum. The first thing I'd like to do is introduce Gabriel Ramos. If you could wave and say hi. He's the student who's working with me on this.
Hi, everybody. I'm Gabe. I'm really excited to be with you and to get to talk about some of our research today.
So Gabe and I will be sharing our presentation today because he's been helping me do some of the legwork to get this project off the ground. So just to let you know that this is brand new research that we have not yet started. Part of what we're doing at the Community Forum today is actually looking for connections with community partners that can help us initiate this research. So let me share my screen with you. Are you all seeing the slideshow? Okay, great. So what I would like to start with is actually something that should not be taken for granted, but is that every day we talk about the number of people who've tested positive for COVID and the number of people who have died, especially in the US, and looking at trends over time, knowing that right now we're in a very dangerous moment. And part of the reason for this research is that although numbers make good headlines, they fail to tell the whole truth. There's a much larger story of COVID that is unfolding at this time, and a much bigger problem that it presents for our citizens in this country than just the number of ill and dead. I am a scholar of structural violence. And so what I'm interested in is these invisible forms of suffering and invisibilized forms of suffering and death that have been caused by COVID, but that tend to get obscured by our focus on statistics. And so I'm asking what forms of suffering and death have been generated by the pandemic, have been caused by the pandemic, but that we don't see and thus don't pay attention to. And in this way, this project would actually have a lot of synergy with the COVID registry in Indiana, because we're looking at people who are marginalized, people whose suffering is not essentially being addressed by the focus on tests and sick and dead. Let's see. Okay. So just a little bit on structural violence. It's a term in peace studies that essentially looks at something that's not hot violence. And here are a couple of examples of structural violence. We know that access to healthcare is vastly unequal amongst community members, especially in St. Joe County. We know that this idea of the essential worker is essentially class differences between those who do not earn very much money, rarely have health insurance, and actually whose job it is to put themselves on the front line of providing services to keep middle-class Americans safe. So when we talk about essential workers, it's often a them versus us, or they are making these sacrifices. And I'm wondering who they are and what it is that they're actually encountering in terms of their day-to-day during this moment. And of course, we know about the disproportionate death rate amongst the BIPOC demographic, but we don't know much behind that would sort of give color to why this takes place, and also potentially hide a lot of other problems that we're seeing, a lot of other forms of suffering within BIPOC demographic. So just to give you a little bit of background on where my questions emerged, I'm a scholar of Sierra Leone, and I did a lot of work on the Ebola epidemic from 2014 to 2016, when again, the two things that kind of came to the attention of the Western world during the Ebola epidemic were scenes of immense suffering. So we saw a lot of photos and a lot of videos of people suffering and dying from Ebola, and the numbers of sick and dead. And there was not much else that kind of came to our attention during the epidemic. And some of the things that were especially problematic at this moment were that, why is it that people were resisting the efforts of the international community? And in the Western world, it's like, oh, well, they're backwards. They don't understand Western medicine. They don't know that we're trying to help them. But what we didn't see is all of the undignified and dehumanizing treatment that they were being subjected to by the international community, who essentially treated them like backward, stupid, unhygienic people who didn't know what was good for them. And things like 21-day quarantines. And we think of a quarantine as, okay, this is something that you do for the greater good. But what happened in quarantines during the Ebola epidemic is that any household that had a positive Ebola test had a 21-day quarantine imposed upon them. But essentially what this meant was that the military would surround their house for 3 weeks and not let them out. And they weren't necessarily providing them food, water, communication, or any of the things that we would consider essential to a period of quarantine. And of course, this is a form of suffering that exacerbated the pandemic because households were predictably breaking quarantine, sneaking out in order to find food. And most importantly, the structure of the ability of hospitals to treat people was severely impacted. Not only were the very few medical workers in the clinics and hospitals completely repurposed to the treating of Ebola, as we're seeing now with COVID, but it also meant that fear of Ebola as it was spreading through the healthcare community means that thousands and thousands of people who went to the hospital for other reasons were turned away. And the death rate from preventable diseases such as diarrhea, malnutrition, norovirus, cholera, these sorts of things that people do not have to die from, basically skyrocketed during the Ebola epidemic. One of the most common forms of death was women dying in labor and childbirth. And there's still no sense of how many people died during the Ebola epidemic that did not have Ebola. But there are a couple of estimates that for every person who died of Ebola during the Ebola epidemic, 4 other people died of non-Ebola causes. So we can kind of translate these questions to the COVID response, and what are the forms of structural violence that we are seeing in the US that would impact the way that people respond to COVID and the way the country itself responds to COVID. So we know that private healthcare is a huge problem with respect to ensuring that people who are sick get care. And it's not just COVID. Even before COVID hit, there was a Guardian poll in 2019 that showed devastatingly that more Americans, 40%, are more afraid of bankruptcy than they are of contracting a life-threatening illness. So whatever the cause of their suffering, 40% of Americans are less likely to go to the hospital than die of their affliction because they are more afraid of bankrupting their family. Now, when I put together this slide, 12 million people have lost jobs that included employer-covered healthcare during the pandemic. And of course, this compounds our first statistic. Even before the epidemic, 40% of Americans were more afraid of bankruptcy. And we wonder what that number might be now that millions of people have lost their healthcare. We also have eviction. There was a federal eviction moratorium that was placed on rent at the beginning of the pandemic. But as that, those protections are actually expiring, and we have over 40 million Americans who are now at risk of eviction because of job loss and an inability to pay rent. And we're actually finding that even during the moratorium, landlords were using other reasons than non-payment of rent to evict families that they didn't want in their properties. One of the most common was members of the household who were living in the household that actually were not on the lease. And this occurred because with the closure of universities, a lot of children moved home that would not otherwise be home. They were trying to e-learn from their homes. They were not on the lease, and tenants use this as landlords use this as a reason to evict their tenants. So the question is, how do we look beyond the headlines and this idea of, the middle class us who are quarantining and trying to be good to discover what the true toll of COVID actually is on our world? And we can do this through some of the questions that have been asked and some of the proposals that have been put forward, such as elderly people should be sacrificed to maintain the health of our economy, squabbling over what counts as a COVID fatality, who actually died of a pre-existing condition rather than COVID. And, is this a problem that a lame duck government should address, or is it something that is the next president's problem? And when you take these questions together, it produces COVID as a political reality rather than as a public health reality. And it's the politics that are causing this excess suffering and death rather than any true failure of public health messaging, such as mask up, hand sanitizer, and the like. And so because of this, I'm launching this project because of COVID, which is how is it that we can kind of grasp the true toll of COVID? What are the forms of suffering? What are the forms of excess death that we are seeing during the pandemic? And so the three questions that you see here are the three questions that are basically guiding the research that Gabe and I will do. How has the COVID epidemic impacted the health and well-being of the most marginal members of our community? What forms of suffering have been deemed acceptable? Are the elderly or those with pre-existing conditions deemed acceptable losses during COVID? And then more generally, what are the sort of people that we are willing, that we seem to be willing to sacrifice to COVID with this idea of the greater good in terms of the economy and the politics of the country? And with that, I'm going to turn this over to Gabe, who has been doing a little bit of pilot research thus far to kind of give you a sense of what we're seeing in terms of suffering and excess death.
Yeah, so I have been doing research essentially on background and on concurrent research with excess death and other sort of forms of ontological violence that are acted upon people during the COVID-19 pandemic. And I really came here today to share not necessarily many very hard numbers, but some anecdotes that to personalize the existence of this reality. So I'd like to start off with two different anecdotes. One actually is a product of a patient that my father had. Not that my father was the provider that delayed care, thankfully. And then another one was actually very widely popularized throughout the news that actually happened at Jamaica Hospital just a few months ago. So harrowingly enough, just to start, the head interventional cardiologist, Dr. Lasik at Jamaica Hospital, said very early on in this pandemic, and has since consequently said that his words ring true, that the toll on non-COVID patients will be much greater than COVID deaths themselves. And he cites an example that he saw in his emergency room where a man, 56 years old, who had a family history of cardiac arrest, had been feeling chest pressure. He called the hospital upon urging of his wife after several days and was advised that due to the COVID-19 outbreak, it was not a good idea for him to come to the hospital for evaluation. So it literally took to the point where he was nearly apoplectic for him to go to the hospital. And then there was an urgent coronary angiography advised a few hours later. And it happened to be too late, this was a preventable death that simply occurred because he was told that it wasn't a good idea for him to come to the hospital. Secondarily, this is local to the Scranton area where I'm from. There was a patient that actually had an ulcer in his foot. And the doctor that was supposed to care for him works in a hospital system that advised providers not to see patients in outpatient care so that they wouldn't bring anything back into the hospital system when they saw patients in inpatient. So the patient's wife was left to care for the patient on her own. This woman is in her mid to late 70s, and she's cleaning the wound without proper education, as the physician would not see the patient due to COVID, nor was she explained for proper protocol for cleaning. After weeks of caring for that patient on her own, the wound continued to worsen and the patient continued to worsen. The physician again did not evaluate the patient. Finally, in desperation, the daughter called my father to see if there was another physician in the area who would be able to help the patient. Throughout the relationship with another institution, my father was able to give the patient an appointment with another surgeon who ended up immediately admitting him, given that at that point he had in his own home become gangrenous and ended up having to have surgery the next morning, consequently losing his leg. Although it's not necessarily a case of death due to the inability of patients to see their doctors during the corona crisis, it's undoubtedly an example of a delay of care. And in that frame, as the pandemic worsens and continues to worsen, systems are overwhelmed with patients and are once again becoming overwhelmed with patients. Physicians will not have resources to provide for all their patients, and inevitably things like this will happen. Secondarily, cancer patients have been really experiencing, I think, maybe the worst, maybe outside of one other group that we'll talk about next, due to this pandemic. So because cancer care usually involves immunosuppressive therapy, tumor resection, and inpatient treatment, a lot of their care has been significantly impeded by a viral inundation in the United States. They have revised protocols to minimize frequency of chemotherapy and degree of immunosuppression so that they don't die of COVID. But at the same token, that's leading to lower incidence of experimental treatments that would otherwise potentially save terminal patients that would have otherwise no recourse for treatment. These are not getting recommended as they could lead to severe immunosuppression and death due to COVID-19. And as one doctor said, again at Jamaica Hospital, he's actually deferring patients that he would otherwise offer enrollment in early phase trials of new experimental drugs and procedures. Now, not only does this have a physical toll on cancer patients, it also has a pretty significant emotional toll. So there was a story of one woman who, on post-mastectomy emotional care and planning, felt alone, in her own words, because there was no face-to-face interaction when she was told that she would need a mastectomy. Compounded by the inability of typical support systems like her family and friends, it was made extremely difficult to cope. She says, cancer is so emotionally loaded. You need some love, and the human part is falling by the wayside. And in reality, I think the conclusion there is that humanity is when sound medical judgment lacking humanity, that's a meaningless thing. That pursuit is not necessarily something conducive to health or growth of patients or doctors. Now, one number that I will give you is that 51% of patients as of July, forget much later on now, reported some sort of impact on their care of virus. And nearly 1 in 4 reported not only a delay in treatment, but also failure to have in-person appointments with their providers, delayed access to imaging, and complete loss of access to support, including physical therapy or mental health care. Consequently, another group that's constantly overlooked, and something that I'm very passionate about as a student, actually the reason why I reached out to Professor Bolten for research, is the impact of our healthcare systems on the homelessness population. So I'll look at one city here. So San Francisco, which has a very high incidence of homelessness. The number of tents in the city, just tents, which may include one or more homeless people in them, increased by 71%, which is a historic raise. And in low income neighborhoods, like where the famous tent city is, the number exploded by 258%. Now, a lot of homeless people depend on plasma donation, especially in the California area due to how high the pay is, especially for the first couple donations, for income, which is by itself a very glaring example of ontological insecurity. But because of that, during a COVID-19 pandemic, only people in confirmed good health can donate. That means that homeless people not only lose their ability to occupy shelters because of the fact that there's no way to confirm that they are safe to live inside of them. They lose up to potentially 104 opportunities to generate income a year. It's particularly bad because not only do homeless people have the capacity to become part of excess death numbers, now people that depend on their plasma also are part of those numbers as well. Now, finally, the last thing I'd like to talk about, I'm sorry for going so quickly, there's a lot of information that I want to make sure that I get through, is transplants. So transplants from brain dead donors are becoming impossible to perform safely because there's no way to confirm that there wasn't some sort of exposure that would lead to a significant increase of viral load in the living patient. So Helen Irving, who is one of a lead doctor in transplants, said the number of potential people that could be organ donors now, it's just significantly decreased point blank. There's no other way of mitigating that. Especially donors that are on life support, that have the greatest load to donate in all of their organs. A lot of those often occurred from accidents or overdoses. Now, many of those donors, because of either just normal day-to-day activities or potential risky behavior that they had partaken in that led to their eventual brain death or life support system, are infected or were infected, which disqualifies them from their organs being used in transplants. Now, in addition, even for valuable, good donors that are cleared to donate, family members cannot be present necessarily to give the required consent for organ donation because hospitals have banned visitors. And a lot of hospitals actually don't allow within their bylaws for over-the-phone consent. So in some reasons where COVID patients have overwhelmed hospitals, not only can people who need non-elective organ donation, organ transplant not receive, there's not room for people who could donate to be bedded in those hospitals. And operating rooms where those transplants could occur have been converted into intensive care units. And that's limited the availability of sites to remove organs from deceased donors and transplant them into new donors as well. Now, especially again, within the homeless community, it's particularly impactful because a lot of the homeless communities are afflicted with severe either mental or physical health issues, and are known as what's called bounce back communities in hospital systems. So unfortunately enough, not only do they lose the ability to go to a shelter, where in this last 6 to 8 months, the incidence of unhoused homelessness has skyrocketed, they can't seek the most immediate means for treatment, which would be an emergency room because they are uninsured. So there's just very significant and very dangerous impacts to COVID that we might not even think about, especially because a lot of these groups that we've discussed today are not necessarily heavily represented within the political sphere, which means that their plights, their needs, and of course, the impact of excess death and COVID-19 has not been widely expressed or received in the media.
Thanks so much, Gabe. So on that, we are happy to thank you for joining us. I will stop sharing my screen. We look forward to questions and contributions, as I said, as this research gets off the ground.
Great, thank you so much. And thank you for all that information. That was really very insightful. So our next panelist would be Terry McDonald, and he is going to be talking to us about the meaning of masks.
Hi, everyone. Let me get my screen sharing here. Why? Let's see, it's not coming up here. Let's see if this works. Hopefully this will be not my email or something. Oh, I have to allow Zoom to share my screen. How fun. I get a new computer and then you don't have all the settings right. Okay, let's see. Okay, let's see if this works now. There we go. Sorry about that technical glitch. Okay, so today I'm going to talk to you about a project I've done on Notre Dame undergraduates and the introduction of mask and distancing mandates. What we've done is put together a survey of Notre Dame undergraduates that is kind of a qualitative longitudinal survey as a way to kind of get at students' observations of mask wearing and distancing, where conflicts emerge, where people don't intervene when someone wasn't wearing a mask but should have been wearing a mask, and just try to get their general impressions of how COVID has affected their kind of experience on campus. So we have 315 unique survey responses from undergraduates over 11 survey waves over the course of the semester. On average, per wave, we got about 28 and a half surveys, and 25 is the median, with 98 unique respondents, but 43 who responded more than 3 times. So we're pretty happy about the kind of response we got from students in participating in the project. So one question we asked was, when did mask wearing become a habit, right? So, it takes a lot to get a group of people to adopt new practices in short order, right? And so how did that happen? How much time did it take? So if you look at this chart, it's a little difficult to interpret, but let me just walk you through it. This is based on a question that we asked students. Based on your observations of other students on campus, is mask commitment going up, staying the same, or going down, right? Or is distancing adherence going up, staying the same, or going down? And then what this graph represents is the kind of going up, the kind of more committed, minus the people who say it's less committed, giving you a net kind of sense of whether things are mostly on the increase or on the decrease. And so if you look at anything above the 0 line, that means the trend is upward, that they think more students are adhering to mandates. And anything below the 0 line means that they think that there's a decrease in mask or distancing. And anything hovering around 0 means kind of stability, steady state. And what you can see here is we saw kind of after the first couple weeks on campus, we saw a pretty big jump in commitment, both for mask wearing and distancing, and then a pretty steady decline with a period of stability. And then we're seeing at the end of the semester more decline. And you can see on here kind of mask wearing range between 86 and 78%. So mask wearing was relatively consistent, but distancing ranged a lot more in how often that happened. Now, if we look at this next chart, this kind of represents this by kind of major moments that happened during the semester. And so you see that increase in commitment coincided with the campus lockdown period. And so where we saw people most committed with numbers above the line of 0 was during that window of the campus lockdown. After that, you see it declines, and you see a little bit more of a decline after the football game, after the Jenkins Rose Garden incident, and then again after the Clemson game. These surveys kind of afterwards catch that downslope. But what you also see is in the middle period, relative stability, where the line is pretty straight, and especially for masks, mostly around 0. And that's pretty indicative of what I found in the research. So if you look at this question of then how does the meaning of mask change over time, and how does that interact with these kinds of moments of stability or instability around mask wearing? You saw early in campus a lot of divergent meanings in early August. Students want that normal college experience, but what counts as normal is different, right? Different students have different expectations of what normal is. For some, normal is partying, having a good time, being sociable. For those people, their interests in what normal was and trying to achieve a normal college experience didn't line up with the mandates that the university was putting forward. And so you saw a group of people for whom mask wearing was objectionable. They wanted to go out and party and hang out with their friends. But then you had another group of people who saw normal as staying on campus. And staying on campus was really important to them. And so they wanted to invest in wearing masks and wanted to invest in distancing mandates so that they could maintain their time on campus, avoid going home and living with their parents again. And so you saw this kind of competition over these kinds of different ways of understanding masks early on in the process. And there were a lot of gray areas around these mandates. What were proper masks? Is a gaiter a proper mask? Is a bandana a proper mask? What do we do when we eat? What are we supposed to do? Are we supposed to wear masks outside or not? When we're running, there were a lot of debates and conversations about what was the right thing to do, and trying to get clarity on these protocols. And students also expected to see serious enforcement. They thought if they weren't going to wear a mask, they were going to get in trouble. And really, they didn't see that happening, right? And so it kind of gave space for more kinds of approaches to thinking about masks because they weren't seeing themselves being punished or their friends being punished for not following the rules. Then we had the lockdown period. Numbers went up, campus shut down, and the conversations about masks changed. Now it became who was wearing a mask and who wasn't wearing a mask. And this became aligned with on-campus versus off-campus kind of struggles, right? Blaming off-campus students for having parties and spreading COVID, and that having effect on on-campus students, especially those on-campus students that wanted to stay on campus for as long as possible. You also see debates about freshmen, right? Freshmen not wearing masks. And an interesting thing about mask wearing among freshmen is that freshmen oftentimes get blamed for not wearing masks outside because my suspicion is that they're trying to make friends and see people's faces. And it's so hard when you don't know anyone to wear masks because it harms the ability to create those social relationships that are so essential for college. And what you saw is this threat of going home made students take responsibility. Even people who might have been dismissive of masks at first realized that if they didn't adhere, right, they could be going home too, and the parties would end just as much as classes would end. So then you got this moment in kind of early September to early October where people got used to it. Masks became unremarkable, and so unremarkable that on the survey they just stopped answering questions about masks. They just said nothing's changed. No one's talking about masks anymore. It's not worth talking about. We all are just kind of doing the thing, and that's that moment of stability I showed you on the chart. And here's just a quick quote about a student who had a friend visit from there was a former St. Mary's alum. And she kept pulling her mask off. And she says, I kept telling her that we all get used to it, but her experience reminded me of how I felt when I first returned to campus under the new guidelines. And so it's become habit at this moment in time in this middle part of the semester. But then we reach fatigue. And so fatigue sets in around October and November. And you see folks getting frustrated and getting tired of following the mandates. Just got more and more tired of mask wearing and distancing, especially distancing. While mask wearing stayed at a pretty good place, distancing just went further and further down the drain. After seeing how Father Jenkins was acting at the beginning and middle of the semester, people started seeing it as more and more of a joke. And then another person notes that people are engaging in common touches. They're touching each other more. They're not doing elbow taps, but they're doing fist bumps, right? And so this kind of the need to be sociable and to connect with each other is starting to override the commitment to those mandates. So what does this story tell us? What does the evidence from the data suggest that might be the challenges that we face going forward in spring with mask adherence? So one major challenge I think we're going to face is that we kind of have three groups. A group that's really committed to masks in all situations, a group who doesn't care about masks and would rather be doing other things or trying to have a normal college experience that involves partying and other stuff. And then you have a situational group, people who are mostly wearing masks, but occasional situations, maybe a football game or maybe at a gathering with some friends might move off of those mandates. And there's a concern I have that that we're with the fatigue, we're going to get more and more people moving towards that situational model, right? Moving more and more towards selecting which situations they feel safer, and then engaging in more risk behavior as that happens. Another major problem that we're going to face is this post-infection licensing problem, where people who have been infected no longer think they need to wear a mask. And so just a couple quotes from the data here. Two friends got freaked out when I wasn't wearing a mask, and I came to hug them to say hello. They berated me to put my mask on. I told them I already had COVID, so I couldn't give them the disease. And they said, "You don't know that." To which I responded, "Yes, I do." They would not stop giving me grief, so I just walked away because I didn't want to wear a mask. Or later, someone says, who got hassled by some ushers, says it's impossible for me to spread or contract corona. So this idea that people think they have permission now, they have the license to be able to go without wearing a mask, is going to be a real problem, because that's going to potentially lead to norm degradation, right? Right now, we have a large portion of students who have already been infected with the coronavirus. And if this becomes normalized to stop wearing masks, this licensing effect, and combined with fatigue, and then combined even with the possibility of increased vaccination, just masks will be less visible, right? And once you see fewer people wearing masks, it might give other people the idea that it's okay for them not to wear masks. So this kind of norm degradation, I think, is a real concern that we're going to face in the spring. And with that, I will end. Thank you so much.
Thank you, Terry. I have actually quite a bit of questions since I was part of the general surveillance strategy task here. So very, very insightful, a lot of the information you just put there. And we hope to get some of the questions out after we have Jerry, who joined us to have our last panelist present. And he's going to be talking to us about tracking the effect of COVID-19 on symptoms of depression and anxiety. Thank you, Jerry.
All right. Hi, thank you. All right, so hopefully you're seeing this. Like you said, so we're going to be talking about COVID and mental health, particularly symptoms of depression and anxiety. I would like to start by thanking 3 of my lab members. Much of what you hear today is the result of their very hard work. So I'd like to start with thanking Lily Brouder, who is a junior in my lab, Marissa Vander, Missen, who is a senior who just graduated. So congratulations to Marissa. And Ellie Gorman, who is also a senior in my lab. So they put a lot of work in to what you're going to see today. So if you've been paying attention to social media and the news, I have no doubt that you have seen some of these headlines. So COVID-19 creates mental health crisis for Generation Z, how to tackle the mental health crisis that will come with a second COVID-19 wave. The US is facing a national mental health crisis. The coming mental health crisis, this is not a normal mental health disaster, and the hidden health crisis. Not to be outdone, Notre Dame was featured with regard to mental health. I think this was on the local CBS affiliate, reporting on our Notre Dame student well-being study, showing that 41% of our students reported experiencing moderate or severe distress during this semester. Now, I think it's easy to believe that there is a mental health crisis, right? So if you've been living in the world in the last 9 months, you've seen how tough it is, you've seen all the things that have been going on, but our subjective experience doesn't always align with what the scientific data says. So let's see, what does the data say? Is there a mental health crisis? So maybe there might be. So there's been a number of studies showing that there's an increase in depressive symptoms since before the pandemic started. There's been a study showing that there is increased suicidal ideation since before the pandemic started. So this would be thoughts about death or suicide. And there's been an increase in distress in a variety of samples, including, like you saw in the Notre Dame students. However, there's also research suggesting that maybe there is not a mental health crisis. So there's at least a study showing there's been no change in depressive and anxious symptoms. There is yet to be a study to show that there is an increase in rates of suicide. There's one study showing that teens seem to be better off than they were 2 years ago, reporting fewer depressive symptoms now than they did pre-pandemic. And the age group that we always worry about, the people over 65 who are at the most danger for the most severe effects of COVID, they are reporting less depression, less anxiety, less substance use, and less suicidal ideation than people who are younger than them. There's been multiple studies showing that people are not more lonely now than they have in the past, which is really surprising, I think, given everything we think about social distancing and all of those sorts of things. And there's actually two studies showing that people have a perceived an increase in social support from pre-pandemic until now. So I would say the support for the crisis idea is mixed right now, and possibly even stronger support for the idea that there is not a mental health crisis. But I think a lot of people would say, well, if we don't know for sure, shouldn't we just assume the worst? Right? It is better to be safe than sorry. That seems to be the idea, right? It's better to be safe than sorry. Assume the worst if we don't know for sure. And I'm going to say no. Do not assume the worst yet. And that is for a couple of reasons. So I think there are three potential problems with sort of promoting or endorsing the crisis narrative that everyone's having mental health problems. So the first problem, I think, is that it has the danger in pathologizing normal reactions to stressful times. I think as a society, we are becoming less and less tolerant of negative moods. If you are feeling sad, if you are feeling anxious, if you're stressed out, that means something is wrong with you. We should all be happy all the time. And I think that is both unrealistic and pretty much goes against everything we know about being a human. To give you a very quick example. So we know that climate change is happening and all the forests are on fire and what have you. So we will imagine that all the grizzly bears are having to move out of their burning homes and come into human society. So, we'll say that as the bears move into town, people are having to encounter them and see them. And we do a survey of people who are having to encounter all these bears. And we find out that 89% of people are reporting moderate or severe levels of distress because of having bears all around. Now, that does not mean, right, you obviously know that does not mean that 89% of people have mental illness. In fact, we'd say that's probably a pretty appropriate reaction to seeing grizzly bears throughout your day. And I think the important thing to catch here with this is that I think there is a movement or at least some opinion that if we don't label your experience as severe, or if we don't label it as being mental illness, that we're implying that we don't care, that we are dismissing your stress, or that we are not acknowledging what you are going through. And that does not have to be the case, right? Just, even if it's appropriate, it doesn't mean we don't care. If someone is running down the street screaming because a bear is chasing them, we will not say, oh, I'd be screaming too if I was getting chased, and we don't care, right? We will still help that person. And so we can still help and still work on prevention, even if you don't have mental illness. One more quick example. Let's say there is a global pandemic and there is illness and death everywhere, and you are going to college, and it is a weird experience because you can't party and hang out with your friends, and you have to wear masks, and you still have the stress of school. And I do a survey, and I find out 41% of you are reporting moderate or severe distress, right? This is what we did find. It does not mean that 41% have mental illness. It's probably a pretty appropriate reaction to what has been a rough year. And again, just because we're not saying it meets criteria for some sort of severe form of psychopathology, it doesn't mean we don't care. It doesn't mean that I don't acknowledge this horrible, stressful year that's been happening. We can do a variety of things, but it doesn't mean that you have mental illness. All right. So again, it doesn't mean we don't care. We can still help, still try to prevent some of these effects of this stressful year. Like I said, number two. All of that was problem number one. Number two is that of promoting the sort of crisis ideas that it's not currently consistent with the science. So like you saw, support is pretty mixed for that idea. And as a scientist, we want to kind of know what's going on and try to be as accurate as possible. And as I'll get to at the end of my talk, if there is a crisis, we should hope there's not, because we're actually not really prepared for a true mental health crisis if there was one. And finally, and perhaps most importantly, is this idea that by promoting this idea that everyone is having mental health problems, that can actually backfire. All right. Again, there's this idea that do anything. Doing something is always better than nothing. Just do something. That's got to be better than nothing. And in reality, that's probably not true. Okay, so it's not true. We know from programs like DARE and therapies like critical incident stress debriefing therapies that there are times when you intervene that can actually lead to worse outcomes than doing absolutely nothing at all and leaving people alone. So both of these programs have this sort of procedure where they do hype up the prevalence. Everybody's using drugs, everybody's using substances, everybody has mental illness. And when you hype the prevalence and you tell people, listen, these are the things you really got to be looking out for. You might have these symptoms and these symptoms. That might mean you have PTSD or whatever it be. When you sort of have this formula, there's been some research showing that that can lead to an increase in the very symptoms you're worried about compared to just leaving people alone and doing absolutely nothing at all. So there is danger that sort of promoting the crisis can backfire. So the three problems are: it pathologizes normal reactions to a rough year, it's not necessarily consistent with the science, and you actually might be doing something harmful. But like I said, the results are mixed. So we've been collecting our own data, and I'll show you briefly what we were finding. So we've been running an online study with 233 adults, ages 18 to 72. It's a younger sample. The median age is 26. We have people from all over the world, 3 continents, half are from North America, pretty evenly distributed with gender, 94 female, 137 male, 2 identified as other. It is homogeneous sample, so it's 73% white. So I think we should keep that in mind when we are trying to make any generalizations about this. But we've been following them since March. So 6 time points from March until a couple of weeks ago. We've been tracking a variety of things, and I'm just going to show you quickly what we found for depressive and anxious symptoms using a measure called the MASQ, which is the Mood and Anxiety Symptom Questionnaire. If there is a mental health crisis, we would probably expect high levels of depression and high levels of anxiety compared to what we've been seeing in the past. And we probably would see those sort of a linear trend of those going up over time as the burden of being part of this pandemic continues to pound on people. All right, so here's one of the findings this is for depressive symptoms. And like I would tell all people or all the students in my class, you always got to pay attention to your y-axis here, right? So the y-axis is higher numbers indicate greater levels of depressive symptoms. But if you look at this range, right? We're going from essentially 67.5 to 75. This scale goes up to 110, and the standard deviation is somewhere near 15. Okay, and we're talking a range between 72.5 and 68. So the fluctuation we are seeing in symptoms is nothing, essentially. This red dotted line that you're seeing here, this is the average score that we found in the past, pre-pandemic. So people are usually scoring about a 68 or so, within that range, pre-pandemic. And over the course of this pandemic, you will see that scores went up a little bit, but not even 5 points. So not even half a standard deviation. They came back down, and now we're again a couple of points away. So I think the message of this is that we're seeing minor increases in depression, but not anything you'd expect at a crisis level. If we look at anxious symptoms of anxiety, you kind of see the same thing. The average score that we have found in the past is 25. Standard deviation on this measure is around 10. And again, if you look at this range, we're talking 25 to 27. We're talking 2 points. Yes, people are a little bit higher than they have been in the past, but again, this has been, pretty steady over the entire course of the pandemic. It is not going up. It's been pretty level. So what we're seeing is we're seeing a steady but small increase in depression and anxiety symptoms. We've looked by age. So if you look by age, people less than 25 do not have significantly more depressive symptoms than people who are over 25. And again, we're limited. We had a younger sample. And same thing with anxiety. We're not seeing any difference by anxiety. If we look by race, you will see that, again, we're right within that range of where we've been. The top panel is depression and the bottom panel is anxiety. And again, we're seeing small increases, but nothing necessarily by particular race. We've looked, one of the hypotheses we had, which I took out because of time, was we looked by whether or not you have kids. And there was really no difference of having kids or not kids for depression and anxiety. So we did see a slight uptick this last month if you have kids. So we'll see if that was just a blip or not. We've looked by continent. But again, the pattern of this data is consistently, we see little increases and they've been stable over time. So the sort of the take-home message from us is that people are more stressed out. It is probably not what we consider a mental health crisis. Promoting that narrative does have the potential to backfire. So I think we have to be careful about that. And then I think the other message is that we should be glad, or at least hope, that this does not turn into a real crisis, because we're probably not prepared for it. Even as people have talked about having crisis and people being stressed out, the sort of main approach to helping them is what I sort of call sort of the spa day approach, is that, take a day off, we'll give you an assignment off, we'll give you some extra credit. And those are great things to do. And I would never want to not do those, but those are things that make life better. But if you have a severe form of mental illness, right? If you are clinically depressed and you can't get out of bed and you are disabled because of that, having some extra credit or having a movie night is not something that moves the needle on that. We need people who are trained in empirically supported treatments. We need to get people who need it into therapy with people who are doing things like cognitive behavioral therapy. There are people who have mental illness. And even before COVID, we were not meeting their needs with empirically supported treatments. So if we weren't meeting their needs then, we have to really hope there isn't a crisis, because it's going to be very hard to meet their needs the way it is now, both at Notre Dame and in the community. We do not have the infrastructure in place to really give good mental health treatment for people who are really suffering. Again, I'd like to thank my students, Lily, Marissa, and Ellie. And I guess we'll end. I'll stop the screen share and I guess we'll take questions.
Thank you, Jerry, so much. And yes, we will start our discussion of our various different, we have a few questions that our participants have started. And I think the first one is for Gab and Kat, and it's based on a comment, I guess, from one of our participants. And it's that non-COVID deaths caused by COVID is one of the areas of concern that they have wondered if anyone was addressing. So the unwillingness or inability to receive non-essential healthcare has definitely impacted my family far more than the virus. So thank you for the work. And to follow up, I was wondering what are the plans to collect this kind of data from our local community? Like, how do you?
Yeah, this is where we were looking to make connections with community partners. Right now, obviously, our data collection is limited by our inability to do face-to-face interviews in kind of an intimate atmosphere. Me being an anthropologist, my approach is generally ethnographic. And so I like to sit down with people, kind of discover what's going on in their everyday lives. And at this moment, we cannot do that, but we can kind of get access to community partners who can help us with a research design that, as the vaccine rolls out, we'll be able to kind of go find people literally where they are and talk to them about how COVID has affected their lives. So I see that this will really unfold more in the aftermath of COVID than it is now. And sort of a way of getting a handle on the true toll is obviously something that is hard to do in the middle of COVID, but it can help us definitely prepare for future pandemics.
Got it. But just for curiosity, do we know if any of the health care providers actually collect data of people that are being sort of either delayed on their processes or even told not to address at all?
That's a really difficult question to answer because we're asking, what aren't they doing rather than what are they doing? And obviously, since healthcare information is privileged information, we would need to go through the process of getting IRB approval to kind of get a handle on these questions. But the things that Gabe was addressing with respect to talking to doctors about patients who've been asked to delay care is a first step.
Got it. Thank you. So this one is for Terry, and more related to the wearing of the mask. Does the outside temperature affect people wearing masks?
Yeah, there's some evidence in the data that students are acknowledge that there's some warmth benefits to wearing masks outside. So that certainly makes it easier to comply once the weather starts getting cool. But my suspicion is that that's not really the area that's the concern, right? Outside mask wearing is less concerning than inside mask wearing among or not among friends and at gatherings. And so I don't think the weather is going to change that, except it creates more opportunities for students to be inside and not wearing masks than before, when they could be outside and enjoying the weather when the weather's warmer. So I think that's another danger we're going to face, that we didn't really have much bad weather in the fall, and students are going to confront that reality pretty quickly once they get back in February. So
I thought it was really interesting how you pointed out how your one of the comments or one of the data that you collected about the fact that because you have already been already had the disease, that you think that you can't transmit it later, right? And we really don't have no evidence of that scientifically yet, right, of really, like what our immunity is and what we build up. But the fact that in our behavior we think, oh, I'm past that, I don't need to, and that students in general. So I think there might be some opportunity there, probably for improved communication and of information to just sort of. Which was very enlightening from your presentation. So
there's a lot of that in the data than I expected. So that's kind of scary for me, that students aren't, they read an article that convinces them that they are safe and that they won't transmit it when we don't really know the science yet. And so there's a real danger there of students acting in ways based on bad information, but that the overall rate of mask wearing goes down, and then social effects, peer effects, right? People start seeing other people not wearing masks, and maybe it's okay if I had COVID not to wear a mask, right? And then we start seeing a decline in that norm, which was so hard to establish. I mean, which I think we really did establish the norm of mask wearing for most of the students. That's the really risky thing, I think, or one of the risky things.
An opportunity for improved communication as we start, I think.
Right.
So the next one is for you as well, Terry. Did you collect data to discern any evident trends on more specific populations of students, for example, freshmen versus seniors, particular colleges, or the role of geography versus hometowns?
Yeah, there's some trickiness in the study. In one respect, I didn't collect any individual data on the people answering the survey because I wanted people to be honest. And so essentially the way the study is done is they get a survey and they ask to report on what they've seen, right? But I don't know who they are or what class year they are. I do know, based on how I sampled them, some information. They're mostly social science students, and they're going to be upper class students because they're majors. So I sampled through departments. That's how I did it. And so I don't get freshmen. So I get a lot of talk of freshmen when upperclassmen are seeing freshmen behave. And so they notice those differences because they're upperclassmen, right? Or off versus on campus kind of dynamics you see a lot of talk about. I don't see much talk about where people are coming from, what their hometowns are, or data that those engineering students over there, right? There isn't much talk of that, so I haven't really seen that. Although from what I understand, there might be some differences between business school and other schools from other data I've heard about, but that didn't really come up as much in my data.
Thank you. I'm going to go ahead and at least get one question in for you, Jerry, before we have to jump off, and it comes to, when did you collect the data? Prior to March 2020? and I'm gonna like jump in on another one there at the same time. And did you see or are you guys see any increase in effects of individuals that already started with mental health illness during this pandemic, or have you looked into that?
Yeah, that's a good question. So as far as starting it, is that in reference to where we were putting those baseline numbers? Yeah. So the depression baseline score was based on stuff from our lab. So I'm a depression researcher, so we give the depression measure pretty often. And that was an aggregate score of stuff that we did probably about a year and a half ago with some, probably another study that we did about 2 or 3 years ago. We really stay around that average. Our college students tend to have slightly lower scores when we do stuff at Notre Dame, but we had data from that same online platform, and that's the average that we went with because we thought that was most comparable, because that was also another global sample. The anxiety symptoms, we don't do that one as much. So we took data from a colleague, Ben Henkin, who's at the University of Illinois, and also Vujanovic, who's at Vermont. And those were data though that were probably from, I don't know, a decade or so ago. Yeah, and I'm sorry, I'm based on your the second question then.
Oh, mainly if you had actually looked to see the effect of the pandemic on people who had already started with mental illness, and if they in that population had there been any.
Yeah, that's a great question. So we haven't done that data. We haven't looked at that yet. So we're still sort of running the study. And I think you're right. So the question would be do people who are already sort of prone to mental illness, does this really give them the extra stressor they need to topple over into sort of severe mental illness? And we'll be looking at that. So we'll be able to control for sort of baseline levels of depression and predict who's getting worse over time. And we have some hypotheses about risk factors for depression in particular. So we study something called hopelessness depression. So we think people who have sort of this negative style of thinking, if there's anybody in this group, we will be able to pick out groups. So when we look, sort of generically at the data, we see this pattern where there's a little increase, but that doesn't mean that there's not at-risk groups in there that it's affecting more than others. And we know, just based on everything we're seeing, the pandemic has done a really horrific job of sort of highlighting systemic racism and biases and things that were there and we didn't see until this played out. So that's possible with mental health as well, I think.
Right. Well, I want to just take this moment now to just remind everybody we will follow up with questions that we couldn't address right now since we're right at the time. And please encourage everybody to reach out to our panelists from right now, from before. Thank you so much, all of our 3 panelists, for all your expertise and all of your contributions. And I want to just also take the moment to thank our organizing and all of our different groups at Notre Dame that help make this possible. Thank you so much to Notre Dame Research and the Health and Wellbeing Initiative, Notre Dame's Office of Clinical Partnership, the SDOW Taskforce, and everybody else here who took the time to participate. And I think we really are hoping that this forums encourage and help us get more partnerships in the community so that we can really empower and make some impact with all the research and things that we're all doing. So really appreciate everyone's time today.